Surgical management of canine hip dysplasia includes prophylactic, salvage, and palliative procedures. Prophylactic procedures aim to prevent or mitigate the development of osteoarthritis in young dogs. Salvage procedures aim to relieve pain and restore joint function in dogs with osteoarthritis. Palliative procedures are less common and aim to alleviate pain. In this video we are going to review the following prophylactic procedures: pubic symphysiotosis and pelvic osteotomy. Juvenile pubic symphysiotosis, JPS, involves electrosurgery to induce necrosis of the chondrocyte in the hyaline cartilage of the pubic symphysis. The following premature closure of the pelvic symphysis limits the growth of the ventral portion of the pelvic canal while the dorsal portion continues to grow normally. This results in external rotation of the acetabulae and increased femoral head coverage, improving hip joint congruence and preventing osteoarthritis. JPS is a minimally invasive procedure recommended for dogs 12 to 20 weeks old with evidence of hip joint laxity. JPS improves hip congruence and reduces laxity in puppies under 24 weeks. Long-term studies demonstrate significant improvement in hip stability, with younger puppies showing greater benefits. However, it is less effective in severe cases of joint incongruency. Studies confirm that treated puppies have significantly less hip dysplasia than control groups at 12 to 18 months. Although rare, potential complications include thermal injury to the urethra or rectum and excessive ventroversion of the acetabulum, leading to subluxation of the femoral head. Studies show no significant differences in pelvic canal width or clinical significance in the shape of the pubic rami post-procedure. The most common long-term complication is lack of efficacy, often due to surgeon error or improper case selection. Corrective pelvic osteotomy aims to reduce joint laxity, normalize joint stresses, and improve joint congruence by causing lateral redirection of the acetabulum. The techniques used are triple pelvic osteotomy, TPO, and double pelvic osteotomy, DPO. TPO involves osteotomies of the pubis, ischium, and ilium, whereas DPO omits the ischial osteotomy. These procedures reduce the forces on the acetabular rim and increase the contact area on the femoral head, mitigating the development and progression of osteoarthritis. The rationale for the development of the double pelvic osteotomy was to reduce the complications associated with the triple pelvic osteotomy. Both procedures have been effective prophylactic measures for appropriately selected patients. During the procedures, patients are positioned in lateral recumbency. The pubic osteotomy is typically performed first, followed by the ischial osteotomy in TPO and the iliac osteotomy in both procedures. The iliac osteotomy involves careful dissection to avoid nerve damage, with plates or screws used for stabilization. DPO generally allows for less lateral rotation of the acetabular segment compared to TPO, resulting in less femoral head coverage, but fewer complications like pelvic canal narrowing. Locking plates have lower screw pull-out rates but risk avulsion. Avulsion of a plate refers to the situation where the plate, along with the screws securing it, is pulled away from the bone. This occurs when the screws, instead of loosening individually, cause a segment of the bone to detach, taking the plate with it. This type of failure is more likely with locking plates, which provide a stronger and more rigid fixation. Ideal candidates for pelvic osteotomy are dogs with hip joint laxity without radiographic evidence of secondary osteoarthritis. Surgery is typically advised for dogs younger than 1 year. While some evidence suggests benefits in skeletally mature dogs, controversy remains about operating on asymptomatic dogs. Reported complication rates for patients undergoing pelvic osteotomy range from 35% to 70%. The most common complications are implant failure, nerve damage, and narrowing of the pelvic canal. Implant failure is defined as loosening of bone fixation because of implant breakage, screw loosening, or plate avulsion. Risk factors for implant failure include insufficient postoperative exercise restriction, excessive body weight, and simultaneous bilateral procedures. With the TPO technique, insufficient purchase of the screws in the sacrum has been reported to increase the risk of screw loosening. Screws placed in the cranial segment of the ilium are more likely to fail than those placed in the caudal segment. With the DPO technique, the use of parallel screws in the caudal segment of the ilium increased the risk of screw and plate pullout. Nerve damage is defined as a physical injury to peripheral nerves caused by compression, contusion, traction, or laceration. Sciatic nerve damage is of major concern about TPO and DPO, but other nerves may also be affected. Compression, contusion, and traction of a nerve may cause neuropraxia, paralysis in the absence of structural changes, which may take weeks to months to resolve. Laceration of the axons with preservation of the perineurium causes axonotmesis, disruption of the axon and myelin sheath but with preservation of connective tissue fragments, which is followed by possible return of nerve function after several months. Neurotmesis is defined as a complete laceration of the nerve, including the perineurium, thereby causing permanent loss of function. Pelvic canal narrowing, mainly a concern after bilateral TPO, is the reduction in the horizontal diameter of the pelvic canal. This can cause constipation, urethral impingement, dysuria, and dystocia. Risk factors include implant failure, excessive acetabular rotation, and pubic osteotomy. It is diagnosed through ventrodorsal radiographs of the pelvis and clinical signs of urethral compression or constipation. Management involves revision surgery for acute cases and corrective osteotomies or total hip replacement for severe chronic cases. Prevention strategies include preferring pubic ostectomies over osteotomies, limiting acetabular ventroversion, avoiding dynamic compression plates for iliac osteotomies, and using techniques to prevent implant failure, especially in heavy dogs. Ineffective control of hip dysplasia and progression of osteoarthritis may occur with improper case selection or inadequate acetabular ventroversion.